Hello and welcome back to CT10. In today's MiniPod, we're going to be focusing on the Pulse Oximeter. We're going to go through how it works, the sources of error, the past SAQs, and then the opening stems associated with this topic. This is really a bread and butter topic that you should know really well. It has some core principles that can be applied to other clinical monitoring and some laws that you just need to know. If you've been enjoying the podcast so far, please subscribe to my YouTube page and check out my other pod called Resident Life. I want to thank you guys for all your support, and with that said, let's dive straight in.
1, 2, 3, 4.
A pulse oximeter is a probe that measures the amount of oxygen bound to hemoglobin in arterial blood and displays this as a percentage. It does this by applying two key principles. The first principle is the absorbance of light at different wavelengths, and the second is the use of the Beer-Lambert law. Now for the viva, you need to be able to just convey these principles in simple layman's terms. You don't want to be confused and go word searching and then end up ruining your rhythm and flow. Now for the purposes of this pod, I'll give the proper definition and then my layman definition. The Beer-Lambert laws are actually two separate laws. The Beer law is the concentration of a given solute in a solvent is determined by the amount of light absorbed by the solute at a specific wavelength. And the Lambert law is that equal parts in the same absorbing medium absorb equal fractions of the light that enters them. These sound confusing, but they're actually quite straightforward. The Beer's law is just saying that if a light is going through a substance, and if that substance has more solutes or more particles, more of that light is going to be absorbed. So the absorbed amount will be increased in proportion to the amount of solutes in that substance. The Lambert law, on the other hand, simply just means that if light has to travel further in a substance, more of that light will be absorbed. I like to think of the Lambert law as length and then relate this back. So L is for Lambert law, which is for length, and then Beer's law refers to the amount of solutes in that substance. Now, when we put these together, we can then say the intensity of light transmitted through a transparent substance decreases exponentially as the concentration of that substance and the distance traveled through that substance increases. We can also attach a mathematical equation to absorbance itself and say that absorbance is equal to the concentration of the solution times the distance of the light pathway times the differing absorbing profile of the individual substance. This differing profile is the second important principle to know when we talk about the pulse oximeter. The pulse oximeter has two unique lights. These are the infrared light and the red light. What makes this monitor unique is that oxyhemoglobin and deoxyhemoglobin have different absorbance of the different lights. Oxyhemoglobin absorbs more of the infrared light, while deoxyhemoglobin absorbs more of the red light. So we can use this knowledge and our knowledge of the Beer-Lambert law to then give us a number that represents the percentage of oxygen that's bound to oxyhemoglobin. Now looking at the oximeter itself, encased within it, we have two high intensity diodes on one side and a photodetector on another side. The two diodes emit a red light at 660 nanometers and an infrared light at 940 nanometers. These numbers are important to remember and unfortunately just a must know. The photodetector on the other side detects the transmitted light and sends this information through to a processor. The diodes emit light in a specific sequence. They're emitting light at a 5 to 10 millisecond frequency, and it starts off being red light only, then infrared light only, and then both lights off so that ambient light can be detected to decrease the interference with their calculations. What the probe is trying to do is separate the arterial pulsations from the venous or static pulsations. And this is when we go back to our Beer-Lambert's law. When there is an arterial pulsation, there's an increase in substance at that site where the SATS probe is sitting. With that increase in blood flow, there's an increased concentration of substance, and there's a slight widening of our finger because of the increased volume. While these are minor changes that we can't see visually, these are major changes that occur that help to separate out oxyhemoglobin from deoxyhemoglobin. During the arterial pulsation, we call this phase the AC phase, so the alternating current phase. Following the arterial pulsation, we call the non-pulsatile phase the DC or the direct current phase. If we create a ratio between this AC phase and DC phase, we can then figure out through a complex mathematical equation how much light was absorbed by oxyhemoglobin itself. The way we do this is use a ratio of absorbance equation. This is commonly referred to as the R equation or the R value, and unfortunately you do have to know this equation for your SAQ answer. This R equation is complex to say in the podcast format, but it's calculated using the AC absorbance divided by the DC absorbance for the red light over the AC absorbance divided by the DC absorbance for the infrared light. Now the R values that are calculated are useless themselves, but they've been calibrated in a series of studies using healthy volunteers who were breathing in increasing hypoxic mixtures from a saturation of 100% down to 75% to come up with a predetermined curve which then correlates the R value to a saturation percentage. This is one of the major pitfalls of the pulse oximeter in that values below 75% have been extrapolated from the data itself, and the significance of this is that they're less accurate. Now, you do have to know some R values and what they correlate to in terms of saturations. The most important is the R value of 0.4 correlates to 100%, an R value of 1 is 85%, and an R value of 3.4 is 0% oxygen saturations. Now that's the pulse oximeter in a nutshell, and it's a lot to take in the first time you go over it. But to summarize, what you have is an equipment that measures the amount of oxygen that's bound to hemoglobin in arterial blood, and it can do this because arterial blood has two special properties. The first one is that oxyhemoglobin absorbs more infrared light than deoxyhemoglobin. And then the second unique thing with arterial blood is that when it goes to the peripheries, it increases the amount of substance at that peripheral site where the oximeter is working. So it increases the concentration, therefore changing the Beer law, and microscopically increasing the length that the light has to travel through, changing the Lambert law. And the difference in absorbance during arterial pulsation, known as the AC pulsation, versus the non-pulsatile phase, the DC phase, which is made up of the venous blood, the skin, the tissues, and represents our baseline absorbance. This difference allows us to make an equation, which is called the ratio absorbance equation, or the R equation. And this R value, which is useless by itself but has been correlated with subjects breathing hypoxic mixtures, and then extrapolated to give us a curve, allows us to put a percentage to the R value. Now let's look at some errors that can occur with the pulse oximeter. The simplest way to think about these errors is to break it down into three different phases. You can have errors at the machine, so with the central processor of the oximeter, errors at the probe level itself, so where there's the interface between the probe and the patient, and then patient-related errors. At the central processor, the biggest error with the pulse oximeter relates back to how the data was extrapolated. Because you couldn't give healthy subjects hypoxic mixtures below 75%, saturation, the pulse oximeter reading becomes increasingly unreliable. Between 70 to 100%, they say there's an error of plus or minus 2 to 3%. Between 50 to 70%, they say there's an error plus or minus 3 to 4%. And below 50%, any value is unreliable. At the same time, the processor takes time to display a value, and this lag time for a signal can be up to 10 to 20 seconds. The effect of this is that there's a delay between what's been measured to what's clinically happening in a patient. And this is why we say if there's an acute problem with the patient, the SATS probe might be the last thing that actually decreases in value. When we go down and look at the probe level, we can think of lots of issues that happen between the probe-patient interface. Commonly, these will be things like poor positioning, movement by the patient, or increase in ambient light. Ambient light becomes an issue because then it starts to affect how much light is absorbed by oxyhemoglobin and deoxyhemoglobin. And the way the probe mitigates that itself is by having that sequence of red light on, infrared light on only, and then both lights off. That's a really easy viva question you can get, and someone can just ask you how often do these lights go on. You don't need to remember the exact number, but if you know 5 to 10 milliseconds, the next question might be, why is it that frequent? And it's to decrease that error by having multiple repeated measurements. Other simple errors that can occur can be that the probe wiring might be disconnected or faulty, or what the probe is measuring might be different. This is where we get into our other hemoglobin species coming in and affecting our normal oxy-deoxyhemoglobin calculations. The two most important dyshemoglobins to be aware of are methemoglobin, which absorbs both infrared light and red light at a 1-to-1 ratio, so therefore our R value is equal to 1, and this is when you have to remember your R values. So if you remember your R value is equal to 1, you'll know that the SATS probe displays 85%. Then we have carboxyhemoglobin, which absorbs more 660 nanometer light, so more red light than it does infrared light. With this, we get a falsely high SATS reading that reads at 96%. Other problems at the interface can be things like nail polish color. Typically, a blue nail polish color will lead to a falsely low SATS probe reading, or drugs that have been given to a patient, such as methylene blue or indocine green, that can also lead to a falsely low reading. Then finally, we can look at the errors from the patient itself. The most common error that's a patient factor is a low output state. So low perfusion pressure will lead to low arterial pulsation, and that ability to separate that AC pulsation from that DC pulsation will be decreased. The way you recognize this is by looking at the plethysmograph and seeing that the tracing is poor and doesn't represent a typical arterial pulse wave tracing, and by clinically examining the patient and feeling the peripheries yourself. Other patient errors can be due to disease states such as severe tricuspid regurg increasing venous pulsations, and now there's confusion created between which is the AC part of our equation and the DC part of our equation. The high venous pulsations can also be created by high IPPV and high peak airway pressures, and less commonly the errors can be created by devices such as an intra-aortic balloon pump, which then confuses the signal again. Going through these errors, you can see why this device is so heavily brought up in SAQs and as viva stems, as this is a core piece of equipment we use on a daily basis with pretty much every patient that we interact with. So let's move on and look at some of these past SAQs then. In 2021 in the first sitting, it was asked, explain how a pulse oximeter works, do not discuss the potential sources of error. This question had a 29% pass rate, just begging to be asked again in the upcoming sittings. As per the examiner report, the major domains assessed here were the system components, the Beer-Lambert law, the differential absorption, the isolation of the pulsatile component, and then the converting ratio of the R to our saturation. What appeared to be the common problems here was incorrect use of terms such as SaO2, SpO2, and PaO2, the misconception that infrared light is the only light that's used in the pulse oximeter, the limited or no application of the Beer-Lambert law, the incorrect or contradictory statements about the absorption spectra of oxyhemoglobin and deoxyhemoglobin, and then absent or insufficient explanation of the pulsatile or the alternating current compartment. There's really not much to add here going through a model answer because it kind of already lays out what we talked about in our summary. Really, as long as you remember the two fundamental processes, the first one being the Beer-Lambert law, which is there to separate out the arterial pulsations from the non-arterial pulsations. The non-arterial pulsations are made up of the venous blood, the tissue, the skin, and all the things that are static. And then the second important principle that oxyhemoglobin and deoxyhemoglobin have different known absorption spectra of light, with oxyhemoglobin absorbing more infrared light, which is 940 nanometers, and deoxyhemoglobin absorbing more red light at 660 nanometers. Using these two principles, we can create an equation, which is the R equation for the ratio of absorbance, and then that gives us a number that we then relate back to our SpO2. In those studies where those numbers were calculated, they were measured using blood samples, so SaO2, and unfortunately you just have to know those R values off the top of your head. So an R of 0.4 is 100%, an R of 1 is 85%, and an R of 3.4 is 0%. The other thing you should incorporate into this answer is the R equation itself, and you should practice writing it down multiple times before the written date. The only other question they can ask with regards to the pulse oximeter was from 2019, which was explain the reasons why a pulse oximeter may give an incorrect reading. Again, this had a low pass rate of 33%, and the common problems included vague statements like causes inaccurate reading, without precise statements of causes of false low reading, given very detailed description of how the pulse oximeter works, but failing to link this to how an error is created, lack of detail or confusion about the mechanism by which the errors are caused, and then again using the terms SaO2 rather than SpO2. To answer this question again, I would break it up into those three factors, which are the intrinsic limitations of the central processor, the errors at the probe level, and then the patient factors. And this is just taken from Propofol Dreams. And to me, this makes a lot of sense. Because if you imagine looking at the probe itself, you can think about what's happening at the monitor when you're seeing it, and then connecting everything down from the wiring to when you go to the patient probe interface, and then going to the patient factors as well. Visually, if you think of it this way, you won't miss a step. And really, you don't want to miss the big ticket items like the intrinsic errors in accuracy with the readings themselves. The biggest risk for an error with a SATS probe is typically movement or malposition. And the biggest error from the patient perspective is typically a lobe output state, leading to poor perfusion. This brings us to our final part of today's MiniPod, which is the opening viva stems. Examiners love the pulse oximeter because there's so many different ways you can approach it and so many tangents you can take as you progress through the viva. The common opening questions are typically, what is the Beer-Lambert law? What is the pulse oximeter? Or describe the principles of the pulse oximeter. When it comes to the Beer-Lambert law, the trick here is to again remember that it's two separate laws. And when you hear the Beer-Lambert law, don't just think about the pulse oximeter. The Beer-Lambert law gets applied in multiple other equipments. One of those is our infrared spectrometry, which gets used to calculate CO2, that you might see commonly used in patients that are up in beach chair positions or having vascular surgeries such as carotid endarterectomies. These equipments are all using the Beer's law and the Lambert's law. When you get asked directly how does the pulse ox work, I would use a nice simple definition like we did at the start of the pod, and then say that it has a few fundamental principles that it uses, mainly the Beer and Lambert law, and the differing absorbance of oxyhemoglobin compared to deoxyhemoglobin. Common weird questions you might get asked about with the pulse oximeter are why do we place it on a patient's finger? If you think about this logically, it's not hard. It just needs to be in a place where there can be some degree of transparency so that light that's emitted by the diode can be captured by the photodetector. So typically these are places like your fingers, your toes, your ears, and your nose. Any other place which is more solid, the light will be completely absorbed, so the photodetector will not have anything to compare the oxyhemoglobin absorbance from the deoxyhemoglobin absorbance. Other questions they love to ask is why did they pick the red light and the infrared light? Now there's no great answer for this. It's simply because these two lights were far enough apart that there was a marked difference between oxyhemoglobin and deoxyhemoglobin absorbance, and they were cheap lights to produce. So historically, it made producing the pulse oximeter easy for the manufacturing companies. The last weird question you might get asked is what is the isobestic point? Now I've purposely left that to the end, and this just refers to the point at which absorption of a certain wavelength of light by two substances is equal. Simply put, this is where oxyhemoglobin and deoxyhemoglobin will absorb the same amount of red light and infrared light. These 2 points correlate to 590 nanometers and 805 nanometers. The clinical relevance of this, I would argue, is low, but in some instances, the isobestic point does get used as a zeroing point to make sure the device is functioning appropriately. The last thing I want to mention about viva topics with a pulse oximeter is that sometimes pulse oximeters can be the end topic of another unrelated topic, or they can be the starting topic to branch out to another discussion. The two common examples is a discussion regarding vasodilators and commonly sodium nitroprusside and how that leads to an increased amount of methemoglobin, and then what the impact of methemoglobin is on the pulse oximeter, leading to a saturation reading of 85% because the R value is equal to 1, or discussions where you start off talking about the pulse oximeter, then you quickly move on to talk about sources of error. You mentioned carbon monoxide and carboxyhemoglobin, followed by a discussion that goes down the carboxyhemoglobin pathway, the avidity of carbon monoxide to hemoglobin, or even worse, talking about how carbon monoxide is used for respiratory function tests, in particular the DLCO. Regardless to say, if you've started off on a different topic and ended up on the pulse oximeter, you're doing really well. Or if you've started off with the pulse oximeter and ended up talking about a completely different topic, you're also doing really well. So this brings us to the end of today's mini-pod. And while it was a pretty straightforward topic on the surface, like all these topics, there's so much to unpack. I hope you guys have enjoyed listening and have a deeper understanding of the pulse oximeter. Given the low pass rates in the previous exams, this topic is just waiting to be asked again. I'll be back next time with another mini pod, and we're going to focus on the neuromuscular junction and succinylmethonium. If you have any questions related to what we've discussed today, just email me at anirudh@sweetdreamsanesthesia.com. Until then, good luck with your studying, and for those that are sitting in August, check out my tips and tricks for the last 2 weeks before the written exam, and I wish you guys the best of luck.